I'm going to speak about multi-level coblation surgery in obese obstructive sleep apnea patients. Some patients, when we see them, they are like this configuration. You can see a lot of patients like this. And so the question is, does coblation surgery, when it is used in a multi-level fashion, can be feasible or successful in such cases or not? My name is Dr. Ahmed Yassin Bagat. I am a lecturer of otolaryngology at Alexandria University in Egypt. I am honored to be a fellow of Professor Claudio Vicini in Italy, Professor Frédéric Chabot in France, and Professor Eric Kizirian and Scott Magginson in US. So I'd like to thank first Professor Yassin Bagat, my father, my teacher, and my support in every step in my career. I can never forget my second father, Professor Claudio Vicini in Italy, and my dear brother and friend Giovanni Camarotto and Filippo Montevecchi, all the staff there in Italy. Thank you so much. Without you, I could never make such a presentation. And I can never start without thanking my dear friend Professor Rodolfo Lugo from Mexico. I hope that we can meet soon after COVID pandemic, and I would like to also to thank my dear colleague and friend Dr. Rocio Campos from Peru. We had 1 month fellowship in Hôpital Foch in Paris, and with Professor Chabot and Dr. Mark Blumen. Thank you so much for allowing us to give this webinar. I have nothing to disclose, no conflict of interest, no commercial benefits from the coblation devices. So, what is coblation? Coblation is controlled ablation. It's a chemical process. It's not a thermal process. It doesn't work by generating heat and cutting tissues. No, it make energy, produces energy at the tip of the wand, and that energy dissociate the medium, the sodium chloride and water, that is the saline medium, to generate what's called excited plasma. What is excited plasma? Excited plasma, like this. You will find at the tip of the coblation there is a light, a yellow light, that is the sodium, and from the sodium chloride you will find hydrogen and oxygen. You will find a lot of vapor. It is not vapor due to heating tissues like in BOVI, no, or in laser, no. It's just a degradation of hydrogen and oxygen, the gas, and free radicals or micro bumps. These micro bumps will keep the tissues and the cells of the tissues excited, and so they will cause tissue breakdown. So the tissue cutting is not generated by thermal energy, it's generated by chemical reaction. Here's a video that shows how coblation is working. This video is coming from Smith & Nephew, and this activated saline, this is what we call the plasma or excited plasma. It vaporizes and ablates one layer of cells, and coblation incorporates a lot of properties. It allows suction, irrigation, and ablation or coagulation at the same time, and you can see, and removal of cells is made layer by layer. Why coblation is better than electrocautery, better than BOVI? Because less temperature. The temperature generated from coblation is a byproduct. It's not generated as the main source of energy to cut tissues. It is generated, so the temperature is from 40 to 70 degrees Celsius. It is cooler than a cup of tea. You can imagine, you can drink a cup of tea at 100 degrees Celsius, but in coblation the generated heat is from 40 to 70, in comparison to electrocautery that is more than 400 degrees Celsius. So this means minimal thermal penetration, minimal dissolution of surrounding tissues, and gentle removal of intended tissues. The coblation wand we usually use in multi-level coblation surgery is EVAC 70 Extra. If you have the high power one, it's better than the usual one. It's 30% longer electrode life compared to the EVAC 70 Extra, the normal one. The HP is better. In courtesy to Professor Claudio Vicini, I took this video and I usually use it in to explain what we are dealing. We are treating the palate, soft palate, and tongue base. These are the main obstructive sites in obstructive sleep apnea patients. In addition to the nose, we have to treat both of them. When we operate on both of them, this is a multi-level surgery. We are not talking about the CALP, the coblation assisted upper airway procedure, the minimal procedure used for stiffening the tissues and channeling the tissues. No, we are talking about two major surgeries that coblation can assist in it. At the level of the palate, this is the idea to do lateral pharyngoplasties and its variants, the expansion pharyngoplasty, the suspension pharyngoplasty, the relocation pharyngoplasty, and the barbed suture pharyngoplasty. That we work on the lateral wall. So when the lateral wall is stiffened, it will support and stiffen also the soft palate itself. So this is the vectors of enlargement, more volume enlargement, no scarring. In comparison to the previous UP3, there was scarring in the middle, and the main vector of enlargement is lateral. This is the evolution from UP3 in the past, from barbed or expansion pharyngoplasty, where you have the scar at the two lateral sides of the soft palate. And this, again, this is the main idea. You take these lateral walls and you relocate or you expand the pharyngeal lumen by relocating them more laterally, anteriorly, and superiorly. This is the main idea of the what we call coblation assisted barbed reposition pharyngoplasty. We use coblation in tonsillectomy. We use again the EVAC extra XP HP. We start to do tonsillectomy again. When you work with coblation, when you use it to cut, keep a distance of about 1 to 2 millimeters between the tissues and the wand tip to allow the exit of saline and to allow to generate plasma. Look at this. This is one of the tricks, very important, to put a piece of gauze here at the posterior pharyngeal wall. It protects the posterior pharyngeal wall from the coblation. In this previous step, you can see that there is a trauma here in the posterior pharyngeal wall. This is one of the previous old videos we did. So I advise you as a simple trick to put a piece of gauze on the posterior pharyngeal wall to protect it, and to put another piece of gauze here on the uvula again to protect it. So two pieces of gauze will make you feel comfortable and to remove the tonsils freely and without bleeding, as you can see, and with instant control of bleeding here. If not, you'll have such trauma in the tip of the uvula and in the posterior pharyngeal wall. What kind of setting you use? We use 7 and 3. This is the default setting of the coblation device. And then we call what we do palate preparation. Palate preparation to do two steps: to cut the palatopharyngeus muscle at the lower part and to ablate the supratonsillar fat, what we call supratonsillar fat ablation. It's very quick. You can use it in eating the fat. This fat will enlarge the supratonsillar area, or this will enlarge what Tucker Woodson said, the lateral palatary space. And then we mark the sites of entry of the barbed suture. We just one point here. This is the same technique as Professor Vicini taught us. One point here in the midline at the junction of the hard and soft palate. Here is a pterygomandibular raphe. Here is the palatopharyngeus muscle. We wanted to reposition this muscle towards the pterygomandibular raphe, and this is a midway point downward, a little bit downward, and midway between the midline and the pterygomandibular raphe. How much fat is removed from the supratonsillar space is variable according to the length of the palate. Sometimes you find a very long palate, and so you need to remove more of the fat. So actually, we palpate the contact point here at the base of the uvula, and we remove the fat until we reach the contact point. Sometimes the palate is horizontal or oblique palate, so we remove a little part of the fat, and sometimes it's vertical palate, and so we remove a lot of supratonsillar fat. This is the idea of supratonsillar fat described by Tucker Woodson and Stuart McKay and I was so happy to meet them in Orlando last February. So this is the obstacles that we need to remove. We use coblation to remove the tonsils and the supratonsillar fat in order to relocate the palatopharyngeal muscle toward the pterygomandibular raphe. This illustration in courtesy to Professor Claudio Vicini. Thank you so much, Prof. And then we use the barbed suture the same as Professor Vicini described. And also we followed Professor Vicini. We used the V-lock suture, absorbable wound closure device. This is a code we use, 30 suture. And here is a simple comparison between V-lock versus the Stratafix. Look at the barbs between here is the long barbs of the V-lock suture, and then when we apply a weight to pull the suture, look at this suture, the V-lock suture is more stable in tissues, and look at the security, the amount of weight needed to remove the suture. This suture can be removed after 16 seconds, while this suture keep more force needed to take the V-lock suture out of the tissues. This is the same diameter of suture, same composition, but the V-lock device provides greater security than Stratafix spiral. There is no conflict of interest, but I found that using the V-lock suture is very useful. Professor Vicini published the barbed suture in a lot of papers, started in April 2015, and I'm happy to be among the authors, and then in a multi-center study in September 2017, and he published recently in October 2019 the prospective randomized trial to prove the effectiveness of barbed suture in his cases. Here's then how to do the barbed reposition pharyngoplasty. We start here from the midline and to a midpoint between the midline and lateral pterygomandibular raphe, the lateral part, and then the site of exit is the same as the site of entry, and then you take first turn, you take two loops around the muscle, and then you come back again to the raphe and again to the muscle and to the raphe and to the muscle and to the raphe. The very good trick I learned from Professor Vicini, not to pull so much on the sutures. Just simple pulling. So you take the muscle and to direct it towards the pterygomandibular raphe. How many loops? I think it's variable. So in this case, we took a lot of loops from the raphe to the muscle and again to the raphe. It depends. Whenever you feel satisfied that the muscle has been well sutured to the raphe, and you can see how the lateral wall is tense now and is more anteriorized palate and stretched. We took a lot of loops in such case, but usually we take at least 3 loops of suture, and at the end we take the suture from one point from pterygomandibular raphe at the base of the uvula toward the other raphe. This will keep the palate more anteriorized and keep it away from the posterior pharyngeal wall, and then we just pull it and cut the suture. Here is the difference between the preoperative picture, where there is no space at all in the posterior retropalatal space, to the postoperative. Immediately postoperative is the tube. You can see how the space is enlarged and how the palate is tense and anteriorized. So the uses of coblation in such cases were to do tonsillectomy, to cut the muscle, and to ablate the supratonsillar fat. This make a lot of rapid and making it quick, least bleeding, immediate suction, no thermal trauma to the tissues, so less edema at the end of surgery. and this will allow you to work on the tongue at the same time, especially in obese patients, narrow field of working. However, some people feel that the coblation, the footprint of the wand of the coblation is not that accurate. It's not like the movie. You are working with a needle, and we discussed that with Smith and Nephew, and they are now making a new, what they call hollow wand in coblation 3 device. It's not yet available, but this is a wand. This is a very fine tip, and so you can work on the palate and you can draw whatever you want on the palate. This is at the level of the palate. What about at the level of the tongue base? Again, we work on the tongue base, not only the tongue base, but also suprahyoid epiglottis, supraglottic structures. Not only the lymphoid tissue, not only lingual tonsillectomy, but also the muscle of the tongue base. What I learned from Professor Vicini, the RoboCob technique, how to do it. Here's the setting, the overall setting. To put the patient in a supine position. Here are the instruments. Here is the vision card, the camera. Here is the coblation device, and on the right side of the patient, on the left side there is the anesthesia setting. We put the patient in a sniffing position, where the head is, the neck is flexed and the head is extended, the same like in robotic surgery. The following pictures were taken from Professor Vicini in the exposure of transoral robotic surgery. We put a pillow under the patient's head in order to make such position. So you put this pillow, and then how about intubation? If you are not working on the nose, we prefer nasal intubation. Otherwise, we put an oral tube. That is normal oral tube and is fixed on the left side. In the previous cases of robotic surgery, Professor Vicini used to do tracheostomy. We don't do tracheostomy in coblation at all. And then exposure of the tongue base. This is the area you want to attack. Here is the tongue base. Here is, if you can see, here is the epiglottis. You want to remove this. If you can expose this picture, it's very easy to use coblation at that tongue base. So the trick in RoboCup technique is to expose cases. This is the trick. You use the same steps as in transoral robotic surgery. We start by taking a suture in the body of the tongue in order to take the oral tongue outside the oral cavity, so keeping the tongue base in vision. Now the tongue base now in vision. Then we use the Davis-Meyer mouth gag. We don't use the FK retractor because this is used for robotic surgery, but we use the Davis-Meyer mouth gag usually used. And we use a short and wide blade because if you use a long blade, it will retract the tongue base, so we don't need this. And if you use a narrow blade, it will make the sides of the tongue prolapse in the field, and you don't use this. So we use a short and wide blade. Where we put the tip of the blade, we put it at the level of the circumvallate papillae, so that you remove what is behind the circumvallate papillae. We don't remove the anterior part of the tongue, anterior to the circumvallate papillae. We don't want to affect the taste of the cases. And then we suspend the patients in a myostand like usual tonsillectomy. And then we use an endoscope holder like this. We use an endoscope holder. This is a simple one used for shooting and for camera, or you can use the Storz one. Here's the vision of the tongue base, or what we usually use, we use a third hand technique, so that your assistant will hold the scope and you are holding the instrument and the coblation wand. And here's the position of the main surgeon at the head of the patient. Usually we are standing and we are following each other on the vision system camera. We have two techniques at the level of the tongue base. We either do the cell technique, just ablation of the tongue base. And again, when we use coblation in ablation, there are many tricks. Keep moving. Don't put the coblation and just wait, but keep moving. Here is another trick. Again, put a small piece of gauze at the posterior pharyngeal wall to avoid trauma to posterior pharyngeal wall. and then we keep removing, as we said, layer by layer of cells until we see the epiglottis. And again, we use ice cream spooning movement of the wand to take the tissues layer by layer until we remove the whole obstructive part of the tongue base. You can use this in either lingual tonsillectomy for non-sleep apnea cases, or in tongue base resection in obstructive sleep apnea cases. So you can see again resection, keeping resection, and immediate hemostasis until now. The guide is the endotracheal tube and the epiglottis. And we remove the all lymphoid tissue in the vallecula. We remove them, and as you can see, at the level of the epiglottis, we usually remove the mucosa of the lingual surface of the epiglottis. We ablate it and cauterize it so that it will make a fibrosis. It will keep the epiglottis close to the resected tongue base, what we call epiglottopexy. Here is the picture at the end. You can see we removed the lymphoid tissue, and we can see from outside, you can see the epiglottis. And at the end, we do hemostasis to make sure that everything is controlled. But in using coblation in tongue base, we don't have at the end of surgery that tissue specimen, so that we can't measure the amount of tissue resected. That's why we started to use coblation in resecting tongue base tissues in order to measure the volume of resected tissues. That's why RoboCup technique. This is a coblation simulation, or the RoboCup technique. This is one of the first cases that we used. This case was already tonsillectomized. We did just tongue-based resection for it, and so we start by demarking the lines or margins of resection anteriorly at the sulcus terminalis, at the juncture of the anterior and posterior tongue, and then here's the incision at the midline, and then laterally at the junction of the tongue base and the tonsil. And whenever we make a grip of tissues, we insert a right angle clamp, and this right angle clamp to hold tissues. And the very important trick is to apply tension of the tissues. And then we start to use coblation in order to working at the level of the muscle, bit by bit, layer by layer, in directing the resection anteriorly toward the epiglottis until we reach the epiglottis. Look, in the first cases, here's the uvula. You are not feeling comfortable with the uvula here. Now we put a suction catheter from the mouth to the oral cavity in order to retract the uvula. And again, we ablate and coagulate the mucosa over the lingual surface of epiglottis. Here's the other side, and we start again holding tissues, and we resect the right part of the tongue base. We keep resecting anteriorly until we reach the epiglottis. And here's at the end of surgery, we have a look at the epiglottis and the complete resection of the tongue base, right and left side. If you have a residual part here, we can ablate it, and we ablate and coagulate the lingual surface of the mucosa over the epiglottis. At this point, we have a piece of tissues after resection, so we can weigh their volume. So we put the tissues in a syringe filled with saline, and we measure the amount of saline increased after putting these tissues. What we found that you need to remove at least 10 cc's. If you remove more than 10 cc's, the success rate is higher. If you remove less than 10 cc's, the success rate is a little bit lower. So resection less than 10 cc is probably not effective, and more than 20 cc's is probably not necessary. These are very important tricks to use during RoboCup technique. Is to put a pressure bandage over the saline to make the saline flow forceful and strong, and again to keep the saline in the fridge 1 or 2 hours before surgery. Ask your nurse to do that to prepare a bandage, a pressure bandage around the saline. Sometimes we use that of the sphygmomanometer, but if you ask, I want to make a pressure of the saline, you will find it in your hospital, and ask your nurse again to put the saline in the fridge 1 or 2 hours before surgery. This will avoid such problem. This will avoid obstruction of the wand by tissues. When you are removing tissues, sometimes you find it very obstructed and clogged, and you need to ask your nurse again and again to freeing the tip of the wand with the flush of saline, and it will make surgery longer. It will make more pressure of the tongue depressor over the tongue, more edema, and but in such cases you will find amazingly that the wand will not obstruct, the electrodes will not break in such like this complication, and your surgery will be faster. You will find that and again, when you have a cold saline, you can control bleeding. You know, when you work in a medium that is very cold, it's better hemostatic and less edema. This is a pre-operative of such cases, and the post-operative, look at the tongue base, how it is huge, and look at after resection, the tongue base and the airway is much better. This is 6 weeks after surgery. We published the RoboCup technique in two papers, the technique itself and its comparison versus the cell technique. Thank you, Professor Claudio Vicini. Thank you, my dear friend Giovanni Camarotto, for helping us. Of course, Professor Yassine Bahagat and Filippo Montevecchi were there. What about the epiglottis? The epiglottis is either this, like this, a trapdoor, or like this. It's squeezed from side to side over the larynx. I advise, if you are working on the palate and the tongue base, if you are doing co-barbed pharyngoplasty and RoboCup technique, please don't resect the epiglottis. If you have such cases in the beginning, I prefer to work on the epiglottis and not to do anything at the tongue base. We can do this with the palate, but don't do 3 major surgery at the same time. We have the barbed, we have the tongue base, and we have the epiglottis. Don't do except 2 of them. If you are doing tongue base and epiglottis, it's okay. I mean epiglottectomy, it's okay. If you are doing palate and epiglottectomy, it's okay, but don't do palate, tongue base, and epiglottectomy at the same time. You'll have a high risk of aspiration, very high risk of post-operative bleeding by the patient coughing. So I prefer, if the epiglottis is like this, is to do it with the palate alone, not with the tongue base. If the epiglottis and tongue base is enlarged, to do epiglottis and tongue base together and the palate in another step. But again, if you are going to work on the epiglottis with the tongue base and the palate, please do just epiglottopexy. Don't do epiglottectomy to avoid aspiration. Here is the final specimen after you perform multi-level coblation surgery. Remove tonsils and supratonsillar fat. We remove the part of the uvula, usually. We remove tongue base, and in the beginning we used to remove also a piece of the epiglottis, suprahyoid epiglottis. And this is the picture of the specimen at the end of surgery. We did a lot of cases in Kuwait. I'd like to thank them. I'd like to mention them, Dr. Abdul Mohsen Al-Turki and Dr. Aladdin. Thank you so much for allowing us to do such cases. All of them were super obese, and the BMI was from 30 to 35, or maybe up more than 35. So we did a good series of cases. We did about 20 cases in Egypt and in Kuwait. All of them were like this neck, and the data are not published yet. We are now finalizing the paper to be published, and but the technique is feasible. You can do a multi-level coblation surgery even in obese cases, because coblation will not allow you to have such a big deal edema at the end of surgery. What about the airway? We usually put the patient in ICU for 1 day overnight. If we are working on the nose, or not, we put a bilateral nasopharyngeal airway. We put that in all cases. Sometimes you look at this, at the end of cases, we put all airways that we have before extubation, and after extubation, make sure that the airway is okay and remove the oropharyngeal airway. We keep this airway for at least 3 to 4 hours, and then we start to remove one by one until the patient is fully awake and is he can swallow and can control his airway, no aspiration. Look at this. This is one of the cases. Even with retrognathia, we could remove part of the tongue base, and that patient improved a lot. How about the pain? We usually it's very painful to work on the tongue base and on the palate at the same time. But if you have such an acute user, the patient-controlled analgesia, when the patient starts to feel pain, he clicks on this button. This contains solution. We put morphine, we put ketorolac, we put Zofran. Zofran is somatriptan, and sometimes we put steroids in it. So, and keep this for 3 days. And the patient is holding it for 3 days. No major pain with such cases. Without this, a lot of complaints about the post-operative pain. But again, don't consider coblation is a magic. It's just a tool. You need to know how to work with it in order to avoid such unfavorable scenario. You can see if you are not aware of the coblation, and if you are, this is one of the first cases. If you are you not have a lot of experience in it, you can have such a complication. A lot of bleeding in a very narrow obese case. Such case, it was very horrible, and in that case we had to do tracheostomy then to protect his airways, and we controlled bleeding transorally, but we did tracheostomy to save the airway too. So to avoid that, I advise you to do at least 10 or 15 tonsillectomies in adults before proceeding to tongue base resection. Or you can avoid that. When you have such vessel, you are prepared with your vascular clips as in transoral robotic surgery, and we can apply also another clip, at least two when you have such a vessel, in order to avoid major bleeding that we have seen before. And then we coagulate, and we cut the vessel slowly, bit by bit, with a coblation device. So now we are secured. So either you do that, or you have to do tracheostomy if a horrible bleeding occurred. So it's not that easy to do a tongue base resection, but in such obese cases. But be prepared for any surprises. How about the future? Look at this. This is Alexandria, my city, during Easter in 2019, before COVID-19. Look at this. A lot of people there. You can't stay in Alexandria during summer. It's full of people. And look at this. This is Alexandria this year during COVID pandemic. Look at this. No, just one car working in the street, maybe checking if there is someone is working there. Nobody there. Same picture, same city, but different situation. So with COVID pandemic, we have to change our strategy. I would say that during COVID, according to International Surgical Sleep Society, we try to avoid multi-level surgery during the pandemic. Don't do palate and tongue base at the same time. I said that you can do it, but don't do it now. At least you can do the major obstructive site first, and then after 1 or 2 months or 3 months, you do the second one. One thing at a time, and that's done well. And so less morbidity, less chance to put the patient in the ICU. As we said, we need to put him for 1 day in the ICU. So we need to save places for COVID cases, so, and avoid major morbidity for the patient. So please don't do what I said. Don't, now, at least for now, we don't do a multi-level surgery during COVID pandemic. I hope that COVID will go away. We have the ninth course on obstructive sleep apnea with cadavers in Dubai next January. And I hope also that the eighth sleep surgery course in Orlando will be scheduled at not virtual next February, 28th February and 1st and 2nd of March next year. And thank you so much. Thank you.